Okay, I think, what's the time? 12:07. We'll get started because it's a long talk and there's a lot to cover. All right, so good afternoon, everybody. So the topic today is a huge topic, CT for evaluation of coronary arteries. So what I can cover in 1 hour, I really had to think about it. And my talk is going to be aimed at really going over the data, the studies that support our current use of cardiac CT in the different clinical scenarios. So this is not a talk where I'm going to teach you how to read CT or go over a lot of interesting cases, because we have a lot of conferences for cases, but we don't often get to talk about all these studies behind what we're doing every day when we're doing the reading sessions with you in the CT reading room. So the way I've structured my talk is we're gonna start with talking about the appropriate use criteria for cardiac CT. They're pretty straightforward at this point. We'll talk about some landmark trials in cardiac CT, and I'll go in detail over 3 major trials. Utility of FFRct, which is obviously something that is very prevalent now. Performing coronary CT in a few special scenarios, such as patients with high calcium score, patients with stents, and patients with bypass grafts. Briefly go over the CTA reporting system, which is the CADS, RADS document. And then we'll finish with Plaque characterization on CTA and some future directions. So this is now 2010 multi-society appropriate use criteria for cardiac CT. As you know, they assign scores to each indication ranging from 1 to 3, which is inappropriate, 4 to 6 meaning uncertain, more research may be necessary, and 7 to 9 is appropriate, meaning the test is generally acceptable for that indication. So for each indication, they break it down by the pretest probability of coronary artery disease, low, intermediate, and high. This is the table going over how the pretest probability is calculated. It's basically based on age, gender, and how typical or atypical your symptoms are. And as you know, generally speaking, coronary CT is appropriate in patients with low to intermediate risk of coronary artery disease, not for high-risk patients or patients having ACS. So these are busy tables, but I want you to focus on just the areas highlighted in red. If you have a pretest probability of coronary artery disease in stable chest pain patients, if the pretest probability is intermediate, that's clearly an A. If it's very low, that it is uncertain, and you can argue in very, very low risk patients, you can get away with just a calcium score and an exercise stress test, and you don't have to do a coronary CT. Patients who are having an ACS with positive biomarkers, definite MI, that's inappropriate. We do not do coronary CT in those patients. So the largest referrals that we get for coronary CT are patients with pretest probability that falls in this low to intermediate risk category who have normal EKG, meaning no concerning ST segment changes and normal cardiac biomarkers. CT is inappropriate in asymptomatic patients without known coronary artery disease. It is uncertain indication to perform CT in patients who have had a cardiac transplant in the past. It is okay to do CT for evaluation of coronary arteries. If you have patients with newly discovered reduced left ventricular ejection fraction, you can send them for cardiac cath, but CT, especially in younger patients, is completely appropriate for that. For pre-op risk stratification, it's appropriate in intermediate risk patients that are undergoing non-coronary cardiac surgery. And there are some other indications that we see on the inpatient side, NSVT, syncope, and these are used. This is interesting. This is type 2 MI, right? So we do a lot of consults on these patients with elevated troponin without any evidence of ACS, and it may be appropriate to do CT in those scenarios. We get a lot of referrals for this indication, which is performing CT when people have already had prior stress test. If you've had a prior normal EKG stress test, but the patient continues to have symptoms, yes, we can go ahead and do a coronary CT. If there are discordant EKG and imaging results, it's appropriate to do CTA. And this is a big one. If someone has had a prior imaging procedure and it showed a mild, for example, reversible defect, it's a U. And if it's moderate or severe defect, then you should go directly for CAT. CT is kind of inappropriate. And if the results were equivocal, then it's appropriate. We'll go over this in more detail in a later slide, which is performing cardiac CT, coronary CT in patients with high calcium score. High calcium score is defined as more than 400. So patients who have calcium score less than 100, considered low, or 100 to 400 is appropriate. More than 400 is a U. And we err on the side of not doing CT when it's extremely high, meaning above 500 to 1,000. And if the, excuse me, even in the setting of a normal prior imaging study, now if the patient is having new or worsening symptoms, it's appropriate to do a CT. It gets an A. It's excellent for evaluation of bypass grafts. It's good for stents if it's a big stent in the left main, stent diameter greater than 3 millimeters, and we'll talk about stents in a bit. So 3 landmark trials in CT that we'll go over. The first one that I personally recruited patients for years ago was the ROMICAT 2, which is chest pain patients in the emergency department, and the second 2 that I'm going to go over are the PROMISE and the Scott Hart trials, and both of them are in an outpatient setting. So ROMICAT 2 published years ago now in New England Journal in 2012, and it was aimed to determine if a strategy of incorporating coronary CT in chest pain patients presenting to the ER is more effective and efficient. The primary endpoint was length of hospital stay. This was a multi-center trial with 9 sites in the US. Before this, there was a ROMICAT 1 trial, which was a single center trial. So the patients obviously did not have ACS. They had symptoms suggestive of angina, but negative biomarkers and negative EKG and no prior history of coronary artery disease. This was restricted to, up until about 5 or 6 in the evening. And they had some secondary endpoints, which were rates of discharge from the ED, major adverse cardiac events just up to 28 days, the cumulative costs of care, and undetected acute coronary syndrome. So this is their primary endpoint, which is the length of hospital stay, which was reduced by about 7.3 hours in the CTA group. So this result was significant for the CT arm. There were more discharges directly from the emergency department, and there were no undetected acute coronary syndromes in patients in either group. There were no significant differences observed in the major adverse cardiac events in 28 days. Undergoing CT did lead to more downstream testing and higher radiation exposure and high rate of invasive coronary angiography in the CT group. And that's a recurrent theme in a number of trials. And when we talk about the Scott Hart trial, I'll show you the data. It's actually fairly common to see increase in coronary angiography and revascularization of cardiac CT in the initial few months. But if you look at long-term after years, it probably is not any greater than doing the functional imaging strategy. The cumulative mean cost of care was similar in both groups. So performing CT, at least in this study, did not really lead to any cost savings. So moving on to PROMISE trial, which was an outpatient trial in the community setting at, I think, 194 sites across the US. Large trial, 10,000 total patients, roughly 5,000 in each arm. And the patients were assigned to an initial anatomical strategy with a coronary CTA or a functional testing, which could be an exercise stress EKG, a nuclear stress testing, or a stress echo. And majority of the patients had symptoms of either chest pain or dyspnea on exertion. So these are patients coming to any clinic, primary care clinics, family medicine clinics, cardiology clinics, other subspecialty clinics. Their composite endpoint was MACE as defined by death, MI, hospitalization for unstable angina. And one of the secondary endpoints was the rate of subsequent cardiac CATs that did not show any obstructive disease. And they looked at radiation exposure. The follow-up was a median follow-up of about 25 months. And their primary endpoint was not significantly different between the two groups, which is the composite of death, MI, and hospitalization for unstable angina, and it was roughly about 3% in either group. And there were less false positives with the CT strategy, meaning when the patients went for cardiac cath, they were less likely to show no obstructive coronary artery disease. As I mentioned before, this is again what keeps the finding that we keep finding in these trials. More patients in the CT group underwent catheterization in the initial few months after randomization. This is the Kaplan markers for their event rates, which are basically similar, with the median duration was 25 months of follow-up. So the conclusion was that in symptomatic patients, outpatients in a community setting with suspected CAD, he required non-invasive testing. A strategy of initial anatomical testing with CTA was not any better in terms of clinical outcomes, but the bigger message here is it was just as good. It wasn't worse than performing the regular stress test. So same year, 2015, this trial came out, the Scott Hart trial from Scotland. This has some different, this is the outpatient setting as well, but has a number of differences compared to the PROMISE trial. So these were patients enrolled from 12 cardiology clinics across Scotland. So these were patients already referred to a cardiology clinic because it was suspected that their chest pain could be angina. So probably the pretest probability was a little bit, move back. Pretest probability was probably a little bit higher than the PROMISE trial. And the primary endpoint is very different. So this trial was not designed to do a head-to-head diagnostic accuracy comparison between two strategies, functional versus anatomical. They wanted to see if adding CT to the standard of care is going to lead to more confidence in a definitive diagnosis of angina, that this chest pain is due to coronary artery disease. So that's what the primary endpoint is, certainty of the diagnosis of angina due to CAD at 6 weeks. Smaller trial than the PROMISE, about 2,000 patients in each arm. And at 6 weeks, they found that overall, there was reclassification of about 27% of patients in the CT arm as opposed to the standard of care arm. And CT definitely increased the certainty of the diagnosis of angina due to CAD. So it's a little bit of a busy figure here. So, but this is how they give the results. Let's focus on diagnosis of angina due to coronary artery disease. So this was the diagnosis, final diagnosis at 6 weeks, rated as yes, probable, unlikely, and no. And then this is the baseline diagnosis. So in standard care plus CTA, you can see 2% that were thought of as having unlikely angina due to CAD are now are a yes, 3% a yes. Conversely, these were a definitive no after CTA, 4% that were labeled as probable and 7% as unlikely. So that the same was not seen in the standard care arm. So the CT did lead to reclassification of at least 20 to 25% of these patients. And that had implication for further testing and the medications that they were given. So patients who had the standard care plus CTA were more likely to get referred for invasive coronary angiography, and a higher percentage of them were started on preventative treatments and anti-anginal treatments. They did report outcomes in this trial that were not significantly different between the two arms. There was a 38% reduction in fatal and non-fatal MI, but it wasn't significant. But then their subsequent study, which is the next slide, is the 5-year outcomes of the Scott Hart trial. So the conclusion from this one was that a strategy, including CTA in addition to standard of care, clarifies the diagnosis and enables targeting of interventions, initiation of treatments, and because of that, may lead to a reduction in the future risk of major adverse cardiac events. So then they published this in 2018 in New England Journal, which was the outcome data at 5 years from this trial. And the primary endpoint was death from coronary artery disease or non-fatal MI at 5 years. Median duration was 4.8 years. And this trial basically showed that the 5-year rate of primary endpoint was lower in the CTA group than in the standard care group, 2.3% versus 3.9%, which was statistically significant. Remember the rates of coronary angiography as well as revascularization were higher in the initial 90 days in the Scott-Hart trial, but at 5 years, actually, the rates of both invasive cath as well as coronary revascularization were the same. So there is an initial difference, but then it levels out. And of course, they continue to find that more preventive and anti-anginal therapies were added in the group that underwent CTA. This is a very, very important trial because this is the big conclusion to make from any study, which is that there is improved outcome at 5 years with respect to major adverse cardiac events in a strategy that employs CTA without resulting in a significantly higher rate of coronary angiography or coronary revascularization. So these are all the different randomized CT trials in patients with stable chest pain. We went over the Scott-Hart and PROMISE. The Scott-Hart showed the reduction in MACE. PROMISE did not show reduction, but remember the median follow-up in PROMISE was 25 months. And they argued that it wasn't really powered to show difference in outcomes. These three trials, CAP, CRESCENT, and the MINT trial had different endpoints based on symptoms. Two of these trials showed different decreased symptoms. This one did not show any difference in symptoms. All right, so let's move on to CT-derived fractional flow reserve. So just like invasive angiography, the parameters that affect FFR on CT are the degree of stenosis, the size of the coronary arteries, and the myocardial mass that is supplied by the stenosed artery. And CT, of course, gives us information that incorporates all these three parameters. HeartFlow is the company that's providing the service across North America. And they have an algorithm involving computational fluid dynamics with anatomical data from CT, which generates these three-dimensional pressure maps, which are color-coded, and lower CT FFR values, abnormal being defined as less than 0.8, are coded as orange, and then deeper shades of orange and red. But it's not just the absolute value, but the drop in CT FFR compared to a proximal segment that's important. So for example, in this CT FFR done on a right coronary artery with significant stenosis, the proximal segment has a CT FFR of 0.98, but in the distal vessels it's 0.8, which is borderline abnormal. What about studies that have actually established that this is diagnostically accurate? There have been many studies, accuracy studies comparing CT FFR to invasive FFR, which would be the gold standard. One of these from Jack in 2019 looked at the diagnostic performance of FFRct and compared it with just coronary CT alone without FFR information, SPECT and PET for ischemia diagnosis. So it's a very interesting study because I don't know if you can get away with this kind of study through your IRB. These 208 patients in the study, within a 2-week period, they had all of these things done: a coronary CT, a SPECT, a PET, and an invasive cardiac cath with assessment of invasive FFR in all three coronary segments. It's from, I think, Netherlands, the study. And then the diagnostic performance was compared with the invasive FFR using less than or equal to 0.8 as abnormal on the invasive FFR. So here are your AUC curves. This is on a per vessel basis. This is on a per patient basis. So CT plus FFR, of course, had the best AUC, the best diagnostic ability to predict FFR less than 0.8 using cath as the standard. The next best was PET. Then this is CT alone, this is SPECT. This is on a per vessel analysis, but on a per patient analysis, actually, PET was the winner, was better than CT plus FFR. So the conclusion was that CT FFR showed higher diagnostic performance that standard coronary CTA, SPECT, and PET on a per vessel basis ischemia, but PET had a more favorable performance on a per patient basis, which may be more relevant.
Can you go back on the graph?
Yes.
So on the per patient level, isn't the AUC 0.95 for CT and FFRct versus 0.91? Although they're not that different, but I'm not really sure if.
0.91 versus 0.95 was not significant.
I know, but.
But they did another analysis which was intention to diagnose analysis, and that's where the PET became statistically superior. Yeah.
Just wanted to make sure.
Dr. Elmala is here.
No, I know, and I'm not.
Process 1/4 of the cases on ACT for CPF. So the entire study had 2 or 8 patients, and they could only process 150.
Yes.
So when you do intention to diagnose, then PET was clearly a winner. And
Yes.
This is PET 015 water. So this is only the flow portion. So you don't have static imaging,
Uh-huh.
you don't have ejection fraction, you don't have. We need to bring Khoram to the PET lab to show how it is.
Yeah, so that's the
Just
intention
listening
to
Dr.
diagnose
Abdullah, I
analysis.
always learn the
Yes.
most, but
Yes.
the data is there out to show you can
It's
twist
like
it
us
as you
comparing
want,
to
but
invasive.
it is what it is.
This is a unique study because all these patients also had invasive cath with FFR measured in all 3 coronary arteries.
Comparisons for invasive.
Yes, compared to invasive FFR less than 0.8 as the cutoff. So moving on, does is FFR associated with adverse outcomes? This is being addressed with the Advanced Registry, which stands for Assessing Diagnostic Value of Non-Invasive FFRct in Coronary Care. It's a international registry of patients from, I think, 38 different sites where they're looking at the relationship of FFRct with downstream care and clinical outcomes. They reported the 1-year outcome on 5,000 patients, and all these patients needed to have at least a 30% stenosis on one of the coronary arteries. And they showed that the major adverse cardiac events were much lower if your CT-FFR is greater than 0.8. And this is the red, which is less than 0.8. When you stratify by different categories of CT-FFR, the lower your CT-FFR, the higher the incidence of major adverse cardiac events. So there is association with outcomes. And revascularization, as you would predict, a much higher rate if your CT-FFR was less than 0.8 compared to greater than 0.8. And of course, the highest revascularization was seen in the group that had both a stenosis greater than 50% on CT as well as a CT-FFR that was abnormal less than or equal to 0.8.
And the FFR is not blinded.
No.
So
No.
again, if
Yeah,
you
so
tell
they're
me
making
my
decisions,
FFR
yes.
is 0.6,
Yes.
then you're gonna revascularize.
Mhm.
Anyways.
So what about using FFRct in, that's what we get at Methodist, complicated multi-vessel coronary artery disease, 3-vessel coronary artery disease. This was partly addressed in the Syntax 3 Revolution trial. So as you know, there's been Syntax 1, Syntax 2. So Syntax score is a score that they have developed to for heart teams to decide whether patients with 3-vessel disease are appropriate for CABG versus PCI, or if either option is equally good. So in the Syntax 3 Revolution trial, they looked at 223 patients that had coronary CT performed with FFR. And there are 2 heart teams. One was provided with the results of invasive cath as well as CT with FFR, and the other heart team was only given results from the invasive cath. And what they saw was that when they were given information with CT and FFR, it changed the heart team's treatment decision making and procedural planning in about 20% of patients. And about 14% of the patients were recategorized from intermediate and high Syntax score to a lower Syntax score. So some key consideration of FFR, it assumes that the patients have received nitroglycerin. It's affected by artifacts. So just when we are struggling to read a study and say, oh, I wish I would have information from FFR to break the tie, it comes back as non-diagnostic because the study is just of poor quality. On average, from different studies, 4 to 10% of studies are of not sufficient quality for performance of FFR. It has limited role in 50% left main stenosis or with critical triple vessel disease. We just talked about 3-vessel disease, but if I'm talking here critical triple vessel disease where, there's no reason to go around doing FFR. That needs revascularization. Remember, in patients with stents, FFRct for the most part can still be performed for non-stented vessels. And then finally, there are other companies that are developing other approaches for calculation of CT-FFR, clearly heart flow, all of them, that may not involve the copyrighted computational fluid dynamic algorithms from HeartFlow. For example, one of them is based on algorithm using machine learning, but they are not FDA approved at this point. So moving on to performing CT in the setting of high calcium score. The bottom line is don't do it. This is an interesting study from JCCT from Cedars-Sinai, where they looked at 119 patients who had a calcium score that was very high, greater than 1,000. Median score was 1,616. And these patients had an invasive cardiac cath and a CT done within 90 days of each other. So you could look at the performance of CT versus invasive cath. And these are some representative images from the paper. So A, B, C, and D are all showing lesions that were called as severely stenotic on CTA, and the cath did not show significant stenosis, and which is the frequent problem with the blooming artifact that calcium. We're going to overcall stenosis. Our positive predictive value and our specificity is going to suffer. So overestimation is the frequent problem, but there were, I think, 3 or 4 patients in the study who had the opposite, where the CT said moderate stenosis and they actually had critical stenosis. So underestimation is possible as well, because these are patients who are going to have a large burden of atherosclerosis, both calcified and non-calcified plaques. So their primary outcome was the vessel-based agreement between CT and invasive cath, defining stenosis as greater than 70%. The negative predictive value, as you would expect, is retained. So if CT was negative, the negative predictive value, both on a per vessel and a per patient basis, is upwards of 90%. There were overall 30 false positives. So CT said significant stenosis, cath was normal, and then those 2 images that I showed you at the bottom are examples of these 3 false negatives. So the conclusion was, with very high calcium score, CT retains a negative predictive value greater than 90%, but frequently overestimates the stenosis. These are 2 examples of cases done in our lab. I showed this case, South Asian male in the MMI conference, and we actually said in this case there was no significant stenosis. This patient had a calcium score of 2,500. But we got lucky because look how it's also how the calcium is distributed. It's distributed evenly across the length of the vessel. And the patient also had a PET subsequently, which was normal. This is the exception. This is the more frequent scenario that we struggle with. Look at all this calcification, and you're kind of at a loss whether there is significant stenosis or not. And that's the reason we cancel them, but we keep getting not just referrals, but people insisting that still do it. All right, so last few words about, excuse me, actually we already went over this. Some of this. So AUC criteria already went over this. Coronary CT performing with stents, so I'll skip that. Now, this is a meta-analysis of 35 studies involving close to 2,700 patients that looked at the accuracy of coronary CT for detection of in-stent restenosis as defined by greater than 50% on invasive cath. And they showed a per stent sensitivity of 0.9 and specificity of 0.94 with some caveats. The stent strut thickness, if it's greater than 100 micrometer, the accuracy, especially the sensitivity, significantly goes down. As in the AUC guidelines, they found if the stent diameter is less than 33 millimeters, the accuracy goes down. If your heart rate was more than 65 beats per minute at the time of the scan, the accuracy is less. And then bifurcation, stents, it's hard to evaluate them. A few things on CT to keep in mind for stent evaluation. Even if someone has a very low BMI, you gotta use at least 100 kV. We use sharp reconstruction kernel depending on the vendor you have. Now we have iterative reconstruction models that can help us with very thin slice reconstructions. The good thing is that most current drug-eluting stents have struts that are less than 100 micrometers thick. Here are examples of cardiac CT with coronary stents. This is what in-stent restenosis will look like. So the contrast is not filling the entire lumen of the stent. You can see here is the hypo-attenuated areas. And when you do the cath, that's a significant lesion in the RCA. This is a patent stent with nice uniform filling of the contrast throughout the stent lumen. So let's move on to the next scenario, which is performing coronary CT with bypass grafts. So it gets a clear A with a score of 8, and that's because grafts are relatively large structures with minimal calcification and motion. So if they are patent, it's easy to visualize them. You may have some trouble at the touchdown sites. If there are a lot of clips there, then there may be a lot of blooming artifact. This is a meta-analysis that looked at 2,482 grafts and looked at the diagnostic performance of CT for diagnosing graft stenosis compared to invasive cardiac cath. And basically, it's excellent. The AUC is 0.99, sensitivity 98%, specificity 98%, and the accuracy was consistent whether it's an arterial graft or a venous graft. So one thing to keep in mind, though, is that even though cardiac CT is excellent for evaluation of the grafts themselves, evaluation of native coronary arteries in these patients is quite challenging because they have a lot of atherosclerotic burden. And studies have shown that the sensitivity for the native vessels is not as good as in patients who haven't had a CABG before. So if graft patency is the primary goal of the study, and the clinician who's ordering, who knows the patient, has to think about that. If graft patency is the primary goal, coronary CT is clearly appropriate. But if evaluation of native coronary arteries is the goal, then also think about functional testing. Here are examples of grafts. This is a case we just read last week. This is a Lima graft going to the LAD. These are MIPT slices. Here's the touchdown site. You can see all the clips. A lot of disease in the proximal LAD. This is the distal part of the graft. This is a saphenous vein graft with probably moderate stenosis in the proximal segment that's eventually going to an OM2. It is patent, and here's an SVG that's headed to the PDA and also supplying blood to this posterior lateral branch. Okay, let's move on to how we report cardiac CT. So CADS-RAD is a document that was initially published in 2016. It stands for Coronary Artery Disease Reporting and Data System, and it was created to standardize CT reporting so that based on CT results, you have more clear guidance about next steps and patient management. So the initial document is from 2016. The revised document was published 2022. Stenosis grading, which I'll show you, is the same between the two. There was no change. The new thing in 2022 is that they have added a system for grading plaque, which goes from P1 to P4. And then there are some changes in the modifiers. Now there is a ischemia I modifier because CT-FFR is done so widely. If you have a positive CT-FFR, you get an I positive for that. And then as a E modifier, which stands for exception, and I'll show you a table that lists some of the exception. There used to be a modifier V standing for vulnerable plaque. That has been replaced with HRP, which is the term for high-risk plaque. So this is how all our reports come out with grading of stenosis. No change between 2016 and 2022 in this CADS-RAD. So we rate the stenosis as nothing, 0%, minimal 1 to 24%, moderate 25 to 49%. Significant stenosis is, moderate 50 to 69%. Significant stenosis is greater than 70%. And then here's their classification scheme for grading the severity of plaques, P1 to P4, that goes from mild, moderate, severe, and extensive amount of plaque. Here are the modifiers. If you have ischemia based on a CT-FFR, you get an I+, and these are some of the exception modifiers, E, which stand for some other pathologies that may be picked up on a coronary CT, such as coronary dissection, anomalous origin of the coronary arteries, and aneurysm or pseudoaneurysm, vasculitis, coronary artery fistula, extrinsic compression of the coronary arteries, for example, anomalous arteries going between aorta and PA, AV malformation, and some other pathologies. So I won't go over these tables, but they have two different tables that not just address the stenosis and the degree of plaque, but then they also go over what future cardiac investigations and managements are suggested based on these results. There is one table for the stable chest pain patients, and then we have another one for acute chest pain patients. And the acute chest pain patients, of course, in the interpretation, the main focus is how likely it is that the patients have an acute coronary syndrome. So that's enough for CADS RADS. So we'll move on to plaque characterization on coronary CT, which is a very interesting area. This was one of the earlier landmark publications looking at plaque characterization on cardiac CT from Dr. Motoyama in Japan. So they looked at the CT plaque characteristics of patients who had acute coronary syndromes versus patients with stable angina. They looked at the vessel remodeling, whether there was any positive remodeling, and they looked at the Hounsfield units of the non-calcified plaque. Less than 30 was defined as a necrotic rich plaque, and 30 to 150 Hounsfield units is a non-calcified plaque that is thought to be as more fibrous. And then they looked at whether there were large calcifications or spotty calcifications. So if you look at this image here, this here is in the green. This is a more fibrous non-calcified plaque with Hounsfield units between 30 and 150. This plaque has a more necrotic rich core with Hounsfield units less than 30. And of course, you're seeing positive remodeling here. Spotty calcification also implies a high-risk plaque, but if there's large chunk of calcium, that's a more stable plaque. A napkin ring sign has also been described, which is basically a plaque with a necrotic rich core. Now these two stars with Hounsfield units of less than 30, that's the core, and then it's surrounded by this fibrous non-calcified plaque with some calcification with Hounsfield units that are above negative 30. So it kind of looks like a napkin ring, so that's another sign that has been described. So the term HRP or high-risk plaque features, there are three features which define a high-risk plaque: a large necrotic core burden, positive remodeling, and a thin inflamed fibrous cap. So we can't look at the thinning of the fibrous cap with inflammation on CT, but that's something that OCT can show. So on CT, we're looking at whether a plaque has the first two features: large necrotic core burden, which is defined as low attenuation areas less than 30 Hounsfield units, or if there is positive remodeling of at least greater than 110%. How is that calculated? By the remodeling index, which is the lesion diameter divided by a proximal normal reference diameter. So if positive remodeling would imply that the diameter at the plaque site is at least 10% larger than the proximal reference segment. So the two FFPs and two FNPs are terms that are used if a plaque has both of these symptoms, both of these features, large necrotic core burden and positive remodeling. That's a two-feature positive plaque. If both of them are absent, that's a two-feature negative plaque. Again, here in yellow is the positive remodeling, and this is a low attenuation plaque with Hounsfield units less than negative 30. What about association of outcomes with high-risk plaque features? So the same group then published this paper in JACC in 2015, where they looked at the presence of high-risk plaque features and stenosis greater than 70% in about 3,000 patients. The interesting thing is that serial CT was performed in 449 of these 3,000 patients, and they looked at plaque progression in these 449 patients, which was actually found to be an independent predictor of acute coronary syndromes. So here are the event rates. Clearly, the HRP high-risk plaque positive patients with high-risk plaque HRP positive have a much higher event rate compared to the HRP negative plaques. This is a nice review in JACC by Dr. Narula, and this really challenges the traditional wisdom that we've all been taught that most acute coronary events result from rupture of claps that are minimally stenotic. Is that really true? Because the CT data suggests that lesions that do not progress rarely lead to events, regardless of the extent of luminal stenosis or the baseline high-risk plaque morphology. So, based on the study I just showed you on other CT data, we know that plaque progression is a necessary step between the early subclinical atherosclerosis and eventual plaque rupture. The plaques may be growing outwards initially, positive remodeling, but eventually those are the plaques that are cause rupture. So this thinking that these are very small plaques who usually rupture and cause ACS is not entirely correct. And that in the paper, they argue has implications for prevention, because if very small plaques are gonna rupture and cause ACS, then what are you gonna do about them, right? So if that is not true, and these plaques can actually progress and accumulate larger necrotic core and develop a thin fibrous cap over time, then all your preventive treatment, statins and everything else is gonna lead to stabilization and maybe reduction in that plaque rather than progression. So what is the future report going to look like? There has been some data that actually suggests that high-risk plaque characteristics by themselves, independent of the degree of stenosis in the coronary artery, can affect the shear stress, the coronary flow, and affect the FFR at that point. So the future of comprehensive CT reporting, this is a sample report from Clearly, will have all of these things: total plaque volume, total non-calcified plaque volume, including the less than 30 Hounsfield units, very low density plaques, stenosis, number of stenosis, how many are moderate and severe stenosis, remodeling index. So all of those things along with FFR value. So, and it's not just Clearly, all the different vendors basically are trying to develop these symptoms now. All right, we're on time here. So last thing I'm gonna talk about is this newly proposed imaging marker of inflammation, right? Because inflammation is the key for progression of atherosclerosis, which is perivascular fat attenuation index. And the pathophysiology behind it is pretty interesting. So it is thought that cytokines that are released from an inflamed segment of a coronary artery diffuse to the perivascular adipose tissue and cause inhibition of adipogenesis. And what that inhibition of adipogenesis is going to do is it's going to shift your Hounsfield units to a more positive value. So a typical perivascular fat will have a Hounsfield unit that could be around negative 190. But as there is inhibition of adipogenesis, that progresses to a higher value closer to negative 30. And so that's really the thinking behind it. This is a paper from the group in Oxford, published in Lancet in 2018. That group has now commercialized it, a company that can provide that to you on your CTs. And here are color-coded diagrams from their paper. So here's negative 190 to minus 30. So they've color-coded it so that higher Hounsfield units are coded as red to indicate more inflammation, right? So when you look here, these areas where you have more red indicating a higher Hounsfield units are supposed to have more coronary inflammation going on, because remember, it's not the inflammation, it's not presenting inflammation in this fat itself, but it's because of the cytokines that are coming from the plaque in the arterial segment that's next to it. And how do we define what is perivascular fat, right? Because you also have fat all around the artery. So perivascular fat, what we look at, is defined as a radial distance that's equal to just the diameter of the vessel itself. So anything outside of that is not accounted for. And then, of course, with AI, they have an algorithm where you put in the data and it'll give you all these nice, beautiful pictures with your fat attenuation index. But they're not the only ones. Siemens has a tool that can do as well, and I'm sure there are other vendors. And in this paper, they actually showed that it is associated with outcomes. Both in their derivation cohort as well as the validation cohort, this is all-cause mortality, this is cardiac mortality, and from their AUC curves, the cutoffs for the fat attenuation index that they came up with was a value of 70.1. So if you have a Hounsfield unit that is more positive, greater than 70.1, that's indicator of increased cardiac mortality. So these curves are basically based on that cutoff. Greater than this would be greater than 70, this would be less than 70. And then, of course, they propose that this could be a very important tool for targeting both primary and secondary prevention strategies in future. So that's all I have. Thank you. We have some time if there are any questions. I hope you remember all these studies now. Yes, Anish.
I have a question regarding the Scott Hart trials.
Regarding what, sorry?
Scott Hart trials.
Yes.
So the primary prevention trials show reduction in MACE, but don't really show obvious reduction in mortality for statins. And secondary prevention trials, they show around 30% reduction in MACE, but modest reduction in mortality. So why would 20% to 20 to 30% uptake of statins and aspirins in a primary prevention cohort based on CT would lead to a dramatic 50% reduction in all-cause mortality?
I think what they're getting at is that you are better risk stratifying patients when you perform a cardiac CT, right? So when you're talking about just the statin primary and secondary prevention trials, these are just patients that you're seeing in the clinic doing your risk calculator, AHA or the Framingham, whatever you're using, and then deciding whether they should be on statin or not. But this is different. But these patients are getting a cardiac CT. So you have a pretest probability from any of those calculators. Now beyond that, now you have information from CT about degree of stenosis and the plaque features, and now they're basing their decisions for anti-anginal treatments and preventive treatments based on that. So when you do that, you're targeting a group of patients that are more likely to benefit from those treatments. And that's the explanation for the 5-year outcomes had a statistically different outcome in mortality, all-cause mortality and cardiac mortality.
Suppose with primary prevention trial, you're probably treating cardiac patient with no chronic disease despite these factors.
If you look at the Jupiter trial, 50% didn't even have a plan. So
Probably not.
you're just placebo for everyone. Right?
Yeah, also it's 20% probably took up.
No, but if even if you take a diabetes, the problem with the primary prevention trials is you take 100 people, almost 50% have no disease. They have no events. But when you limit it to those with very high burden of disease, that's only about 15 to 20%. Now you try to extrapolate for the entire population, that becomes a challenge. One possible, and then again, future studies again would be needed. One is this is a group where they truly had a significant portion of those with high disease. But you're right, it's getting challenging now. Whether revascularization in the right patient type or not, we don't really know. But only one study we need.
Even among diabetes, I mean, it shows that the outcomes are very good.
I guess if you had calcium score in the functional arm, would you see the same difference?
Possibly.
One of the challenges with showing outcome differences, what they talk about in the discussion of the PROMISE trial, is that most patients are getting such good preventive treatments now that it's very difficult to show outcomes data based on just a different testing strategy. So, the overall event rate of the adverse events in PROMISE was around 3%, which was actually lower than what they had thought it would be. So they argue that you would either need a much larger sample size, even though this was 10,000 patients, or you would need to have a test that has a much higher incremental value for future treatment decisions, which can impact outcomes.
For me, the main message in PROMISE was we're just
As good.
using advanced testing
Yeah.
too much. Because if
Okay.
you look at functional testing, almost 90% had normal functional testing. Even if you look at the CTA, 90% didn't have obstructive disease. Even any disease, any plaque was 50% in so-called high intermediate pretest probability.
Mhm.
So you can take 10 patients coming with a pretest probability, intermediate, and do a functional testing, and you can sit in another room and read them all normal, it will be 90% accurate. I just think we're doing too much advanced testing, and hence we need a gatekeeper mechanism where, in this day and age, with this high population, if you're going to have 50% normal CTAs, there's something wrong in our approach. And the approach is totally inaccurate, and that's where I think that calcium score gatekeeper role comes in.
Yes.
That's been really
Yes.
proven in the Denmark study and many of the other.
Absolutely.
Hopefully the guidelines will
So not
minimize that.
very low and low risk patients, I mean, that's totally appropriate just to do a calcium score. Also, I showed data from one of the study. It is true that, I mean, you may think, oh, CT causes a lot of false positive results, but that's only true when your calcium score is very high. Otherwise, it doesn't. The positive predictive value on specificity is very good, upwards of 85%. So in the PROMISE trial also, they saw that actually the number of people who were going for cardiac cath and ended up having no obstructive disease was much higher if you'd done a stress test, stress test calling moderate defect but normal coronaries, much less likely in appropriately selected patients when you do a CT.
So Dr. Ahmed, do you think we should be reporting in CADS-RAD staff?
It's a good document. Some of it is, the degree of stenosis, yes, everybody needs to report it on the same. And yes, the plaques, we say mild, moderate, severe, right? But beyond that, to plug in all those management decisions and what should be the further testing, I mean, the clinicians know that. You don't have to look at a table for that. I think just the stenosis and the plaque assessment is enough. And then, of course, there's other pathology or abnormal CT, FFR, you'll report that. But, if you've made your report totally in that format where it's just a lot of scores, I don't think that really helps the clinicians. Now we're going to, I guess, devise our templates again, Dr. Chang, when we go to singles, we can think about that.
No, I mean, definitely. Mostly made
Yeah. I think the main thing is, these are everybody's ordering them, PCPs, family physicians. The reports should not be confusing. They should come out as very, they can understand them very clearly. All right, thank you very much. Sorry, there was no lunch. I have to ask Myra what happened.